In a series of 6 presentations, we will explain the basics of the cardiovascular model. Often the model is based on existing knowledge, sometimes with a slight shift of emphasis, sometimes with a reinterpretation. In one specific aspect, the model is based upon a new theoretical concept, namely the theory of arterial acceleration, that was published in 2014. The first presentation will deal with the CNS ischemic response, as underlying factors observing the adaptation of cardiovascular control to metabolic demand. Any living organism that is present on Earth nowadays requires energy to maintain its structural integrity. Also, it requires energy to actively interact with the environment, not in the last place for the purpose of reproduction. This has proven beneficial for species survival up to this point in time. Some kind of consciousness has proven beneficial to species survival in the past. Consciousness is the epiphenomenon of a series of physiological processes, all subserving the high energy demand of electrical activity in the brain. Neurons depend fully on glucose oxygenation, and therefore consciousness is rapidly lost when there is an interruption in the supply of glucose, of oxygen, or of both to the brain. For instance, consciousness may rapidly be lost when a diabetic patient has injected too much insulin, causing hypoglycemia, or when oxygen supply is impaired by carbon monoxide poisoning. Although the brain is only 2% of body mass, it is responsible for 20% of all oxygen and 25% of all glucose consumption, demonstrating its huge metabolic activity. At the microvascular level, the amount of blood delivered to a brain region is linearly related to local metabolic activity by a signal based upon the waste products of this activity. The signal is presumably transmitted by glial components, such as astrocytes, since apart from the area postrema in the medulla oblongata, there is no direct contact between neurons and cerebral capillaries. In human subjects, the effect of metabolic coupling can be demonstrated by performing a CO2 reactivity test. Subjects are asked to perform a period of forced breathing or hyperventilation, causing a drop in blood carbon dioxide, or they are asked to do a CO2 retention test by rebreathing in a closed compartment, for instance in a plastic bag, causing blood carbon dioxide to accumulate within the body. Global changes in brain perfusion can be monitored non-invasively by mounting transcranial Doppler probes to the subject's head. Ultrasound waves can reach the basal arteries of the brain through a thin window in the temporal bone. In this way, blood flow velocities can safely be measured over prolonged periods of time. The result of these tests can be seen on this slide. Despite no obvious change in blood pressure, which is the red curve, or heart rate, which is the blue curve, the flow velocities in the right and left middle cerebral artery, which are the green and gray curves, decrease during a period of hyperventilation, indicated by the level of end-tidal CO2, indicated by the orange curve. The opposite occurs during a CO2 retention test that shows increased flow velocities in the right and left middle cerebral artery in response to a rise in end-tidal CO2. The mean flow velocity in both arteries can then be graphed in relation to the end-tidal CO2 as shown on the right, indicating an almost linear relationship between both. The increase in middle cerebral artery flow velocity during CO2 retention has traditionally been attributed to widespread cerebral vasodilatation alone, caused by fooling the metabolic coupling. However, when recording arterial blood pressure simultaneously, which is the red curve, it becomes clear that there is also a systemic response to the CO2 challenge. Theoretically, an increase in cerebral blood flow during CO2 retention can occur because of 1. Cerebral vasodilatation, 2. An increase in systemic vascular resistance directing the blood preferably to the brain, 3. An increase in heart contractility, and 4. An increase in cardiac output by increasing the venous return to the heart. In the diagram at the right, an attempt has been made to relate these different possibilities to the morphology of the blood flow velocity signal. We will come back to this at a later stage. Let's look at cardiac function first. The most important principle governing stroke volume is the Frank-Starling law. Basically, this says that the stroke volume is related to the end diastolic volume. The more blood enters into the ventricle, the more blood is ejected from the heart. When the filling time decreases because of tachycardia, the stroke volume will also become smaller. So cardiac output, which is heart rate times stroke volume, cannot be increased by increasing heart rate alone. In order to increase cardiac output, we will also need to improve ventricular filling by increasing the preload to the heart. There is a relation between cardiac output and right atrial pressure. This is shown in the graph on this slide. Up to a certain maximum, cardiac output rises in relation to right atrial pressure. The maximum to be reached depends on cardiac function, e.g. cardiac ejection fraction and cardiac contractility. Based upon the Frank-Starling law, the heart will eject more or less blood based upon ventricular filling, thus upon right atrial pressure and filling time, or preload, and irrespective of the prevailing arterial blood pressure or afterload. The heart is a volume pump and not a pressure pump. Consequently, when considering the vascular system over time as a whole, we should think of this as blood volumes that fill either the arterial or the venous side, and for the special purpose of brain perfusion, either the vessels leading to and from the brain or to and from the rest of the body. In this helicopter view, the heart is only a driving force allowing the blood to move. The relative distribution of the total blood volume over the four basic components of this system is the product of cardiovascular control. The most important mechanism moving blood from the venous to the arterial side of the system is the CNS ischemic response. When ischemia is detected by central chemoreceptors in the medulla oblongata, for instance during CO2 retention, the sympathetic nervous system is activated, causing not only arterial but also venous constriction. Venous constriction will increase the preload to the heart and thus cardiac output. In this way, the blood flow to the brain increases, as we have seen during CO2 reactivity testing. We believe that the CNS ischemic response is continuously active, centrally monitoring the systemic metabolic rate in the brain and regulating cardiac output by changing the venous capacitance and thus the preload to the heart. In the next presentation, we will look at the arterial side of the vascular system and discuss the anatomical and physiological aspects involved in blood supply to all the body tissues.